Hello everyone. So, please let me know if my audio and video is good. Please let me know in the chat box if my audio and video is good. Okay. So, let us start with the recall discussion of INICET medicine questions asked for November 2025. So, these questions that I'll be discussing are based on the recalls that I've got from the students who have given the exam. So I personally have not given the exam. So what we are trying to do is to give you a close simulation of the actual questions that were asked for the exam. And the essential idea is to understand the gist and understand the concepts properly. Okay. So let us move on to the question discussion, right? Okay, right. So coming to the first question, a very simple question. Which of the following drugs is not used in the management of status epilepticus? So status epilepticus, always an important topic for both INICET and NEET PG. Out of the options given, the valproate, levetiracetam and fosphenytoin are drugs which can be used in the management of status epilepticus. But when it comes to option B, that is ethosuximide, we all know that ethosuximide, the only FDA approved indication for ethosuximide is in the management of typical absence seizures. Just that and nothing else. The answer for this question will be option B, ethosuximide. Okay, right. A patient presents to the emergency department after a road traffic accident with history of vomiting and loss of consciousness. Non-contrast CT brain is shown, which is the most appropriate next step in the management. So the non-contrast CT was suggestive of a biconvex hyperdensity, most likely suggesting an extradural hemorrhage, an EDH, possibly as a sequelae to the head trauma. And the patient has developed features of raised intracranial tension. That is why patient is having vomiting and loss of consciousness. So what is the most appropriate next step in the management was the question. First option, decompressive craniectomy. Second option, observation in ICU. Third option, conservative management. And fourth option will be burr-hole evacuation. So it is clear that observation in ICU will not be the option for such a condition. And again, conservative management may not be adequate because the patient is already in a critical state. Now, between decompressive craniectomy and burr-hole evacuation, some students were of the opinion that in the exam, craniotomy was asked, but from the recall that I've got from most of the students, they said it was specifically on decompressive craniectomy. So when you compare option A and option D, so here you're going to evacuate the blood out. So in that case, you have got two options. One will be a burr-hole evacuation, and the other option will be a craniotomy and evacuation. But since the option of craniotomy was not there, I think it is quite straightforward. The answer will be a burr-hole evacuation. Regarding the option A, decompressive craniectomy, this is used in case of significantly raised intracranial tension that can occur in the context of a large stroke. In such a case, a large stroke causing cytotoxic edema, in such a case, you will go for decompressive craniectomy, but that is not the scenario here. Hence, the best option will be option D, burr-hole evacuation. Clear? Right. Let's go to the next question. A patient presents with bilateral lower limb weakness, and on examination, dorsal spine tenderness is noted. You suspect compressive myelopathy. Which of the following findings supports your diagnosis? The options being hypotonia, knee clonus, negative Babinski sign, presence of cremastic reflex. So when you have a patient presenting with lower limb weakness, we know that any motor symptom can either be upper motor neuron type or lower motor neuron type. All throughout my lectures, I've always stressed the importance of understanding the difference between UMN and LMN with regards to neurology class that I take. And please understand this has been tested again and again. Be it in 2022 May, even in 2024, one of the INI papers had a question testing the basic concepts of UMN versus LMN. So that is a very important concept that you've got to understand. Now, you can see that in the question, there is a specific mention of dorsal spine tenderness. So in a patient with a paraplegia or paraparesis, when you have a specific spinal tenderness, yes, this is pointing towards a diagnosis of a compressive myelopathy. Now, when you talk about a compressive myelopathy causing weakness, are you thinking about upper motor neuron type of weakness or lower motor neuron type of weakness? You are thinking about upper motor neuron type of weakness. Now, go through the options. If you look at the option hypotonia, it is a feature that is suggestive of LMN type of weakness. There is nothing in the question that suggests a diagnosis of LMN type of involvement. Then coming to the Babinski sign, well, you would expect a positive Babinski sign in this patient, right? And presence of cremastic reflex again is not a finding that is going to support the diagnosis. For this particular question, clonus will be a finding, whether it be ankle clonus or your patellar clonus or knee clonus, that is going to suggest a diagnosis of or a finding that is in favor of a UMN type of lesion. So the answer for this question will be option B, that is going to be knee clonus. And can you tell me what is the relevance of knee clonus or ankle clonus in the context of UMN lesion? It suggests a significant damage to the corticospinal tract. It is an extensive damage to the corticospinal tract that you get clonus as a feature. Very clear? Okay. A 28-year-old man presents with involuntary movements of the upper and lower part of face and dance-like movements of the limbs. He exhibits aggression and irritability. MRI brain shows hyperintensities in both caudate nuclei. So what many students told me is that the specific MRI finding was described as a part of the question itself. What is the most likely diagnosis? A similar image was given. MRI T2 flare axial section was given. The options being Huntington disease, Sydenham chorea, tardive dyskinesia, and Tourette's syndrome. Look, it is regarding a young adult, 28-year-old male, and what is the symptomatology? Involuntary movements. And these movements are involving upper and lower part of face. Okay, along with dance-like movements. When you hear about dance-like movements in the context of a movement disorder, what are you thinking about? You are thinking about a probable phenomenology of chorea. This could be a choreiform movement. Yes, this could be choreiform movement. And in case of which disorder can chorea occur along with certain cognitive impairment and psychiatric issues like aggression and irritability? Yes, you are probably thinking about Huntington's disease. We know that patients with Huntington disease can have a wide age group of presentation. So even a 28-year-old male can also present with Huntington disease. Probably this is one sort of Huntington disease which has been strongly inherited in the family, which is why you will have an earlier occurrence of the disease. That phenomenology is called what? Anticipation. So this is probably a case of a Huntington disease with a significant anticipation occurring in the patient. And the MRI brain is showing hyperintensities. So is the finding of the imaging suggestive of Huntington's? The answer is yes. If you look at this axial section, there are two findings that you can observe. One is definitely in the region of basal ganglia, particularly the caudate nucleus. You can see hyperintensities, and not just that, you can see that the size of the frontal horn of lateral ventricle is slightly enlarged. The reason being, normally the caudate nucleus, which is situated somewhere here, will have a pushing effect on the lateral ventricle. But when there is a caudate atrophy, we know that in case of Huntington disease, there is significant atrophy of the caudate and putamen, because of which the ventricles slightly open up. So that also can be noticed. But again, it would always have been better at a NEET PG level if comparative imaging of a normal patient was provided. But whatever be the case, with such sort of history being given, and the diagnosis is almost staring at you even without looking at the MRI image. And if you look at the other options, Sydenham chorea, well, it is not going to have other features like aggression, irritability. So those features are less likely in case of Huntington's, in case of Sydenham chorea, and also the MRI findings does not occur. Tardive dyskinesia, again, there is nothing that is suggestive of development of tardive dyskinesia, and again Tourette syndrome, nor is the clinical feature suggestive of Tourette syndrome. We are not getting a description of any sort of tic. If it was Tourette syndrome, you would have had the patient having motor tic, vocal tic, along with certain behavioral abnormalities like ADHD and obsessive compulsive disorder. For this question, the best answer will be option A, Huntington disease. Okay. I just want to show you this section from Harrison's textbook. Again, in the chapter on Huntington disease, you can very well see in the coronal section, the first one, you can see the boxcar ventricles, the typical imaging finding, boxcar ventricles, you can very well see. And in the second image, which is the axial flare image, again you can see the basal ganglia hyperintensities with again slight opening up of the lateral ventricles. Okay, right. Okay, so a patient with schizophrenia was started on haloperidol and later develops high-grade fever and generalized muscle rigidity. What is the next best step in the management? The options are: stop the offending drug and start dantrolene or bromocriptine. Option B, continue antipsychotics and ensure hydration. Option C, start benzodiazepines. And option D, administer anticholinergic agents. Well, a similar sort of question was asked in May 2022. Not exactly this one, but again, in the context of schizophrenia and starting off another antipsychotic, which led to an acute dystonic reaction. But this time, they've slightly twisted the question. This is regarding the clinical scenario of a patient who has presented with neuroleptic malignant syndrome. So the administration of haloperidol, which is an antipsychotic, also referred to as neuroleptic, right? Antipsychotics are also referred to as neuroleptics. So in the context of such a drug administration, when a patient develops fever with generalized muscle rigidity, the first differential diagnosis in your mind has to be neuroleptic malignant syndrome. And when it comes to the management of neuroleptic malignant syndrome, the first and foremost step would be to stop the drug, stop the offending antipsychotic drug, and then you will have to start a drug like dantrolene, or you can go for bromocriptine. So that would be the answer for this question. Regarding other options, continuing the antipsychotics would be such a crazy idea. Start benzodiazepine, not the best choice here. Start the anticholinergic agents, again, no. So the issue here is neuroleptic malignant syndrome, and the management here is to stop the drug and to start dantrolene or bromocriptine. Okay. Right. In a patient with myasthenia gravis, repetitive nerve stimulation shows decremental response. So the topic of neuromuscular junction has been tested here. The question is on the primary mechanism responsible for the decremental response on RNS. So look at the first option, reduced calcium influx into the presynaptic terminal, which is not the answer. We know that this first point is regarding the pathogenesis of Lambert-Eaton myasthenic syndrome and not myasthenia gravis. Decreased number of acetylcholine receptors on the post-synaptic membrane. Definitely, yes, it is related to the pathophysiology of myasthenia gravis. Reduced acetylcholine release from the presynaptic terminal. Again, no. Decreased amplitude of nerve impulse. Again, that is not the best answer here. So the best answer would be option B in this case. Okay. Which of the following statements about rimegepant is correct? The first option, it is a partial CGRP receptor agonist. It is wrong. We know that rimegepant is a newer drug for migraine. And what is the mechanism of action? It is a CGRP receptor antagonist. Next option, it is used in the treatment of migraine, acute treatment of migraine. Absolutely right. It can be used in the acute treatment of migraine. Next, it is administered as subcutaneous injection. False. It is given as oral drug. Next option, it causes vasoconstriction. Again, false. It is antagonizing the effect of CGRP. So CGRP causes vasodilation, and this particular drug antagonizes the effect of CGRP. But this drug per se is not going to cause any sort of vasoconstriction. Hence, the best answer for this question is going to be option B. Okay. So most common site of aneurysm in circle of Willis, is it anterior cerebral artery, middle cerebral artery, vertebral artery, and basilar artery? So for this question, actually, you know that in my lectures also I've taught you the most common location of saccular aneurysm or berry aneurysm. Remember, most of the intracranial aneurysms, almost 90% of them are the saccular or berry aneurysms. All the other type of aneurysms like dissecting aneurysm, would be only to a lesser extent. So majority is saccular aneurysm. Okay. So what is the most common site? Actually, the most common site, it is the junction of anterior cerebral artery with anterior communicating artery. That is the best answer. Okay. Now, though the question looks apparently simple to many of you, I think it is not that easy, and there is a slight controversy to this. Let me just explain. Most common site of aneurysm was asked, not per se a ruptured aneurysm, just the question was most common site of aneurysm. Now, I agree to one fact, that when you look at the aneurysms, let me just show you a screenshot from the Adam and Victor's textbook of neurology. And as you can see, when you talk about saccular aneurysms, most of them would lie in the anterior part of the circle of Willis. And they have quoted that the 4 most common sites include the proximal portions of the anterior communicating artery, number 1. Number 2, at the origin of the posterior communicating artery from the stem of the internal carotid. Then at the first major bifurcation of the middle cerebral artery. And number 4, at the bifurcation of internal carotid artery into middle and anterior cerebral artery. So it is not a direct mention of anterior cerebral artery. You can see that the proximal portions of the anterior communicating artery is what is actually mentioned. Now, see, when it comes to the question, it is easy to make an assumption that, okay, the anterior communicating artery is not given, so this could be anterior cerebral artery. But if you look at the data, there is no definite reference like that. Okay, I can only assume that with the options given, which is the recall that I've got from the students, yes, it is the proximal part, which means almost close to the anterior cerebral artery. But the problem is when you look at more data, I'll just show you one screenshot. And this screenshot is from the 22nd edition of Harrison. 22nd, the current latest edition of Harrison. You please look at this. This is an image exactly taken from the book, The View of the Major Blood Vessels Supplying the Brain and the Location of Saccular Aneurysm. According to this particular table, if you can see, anterior communicating artery, they have given as 12 percentage. Internal carotid artery, 30 percentage. Posterior communicating artery, 12 percentage. Middle cerebral artery is 34 percentage. Now, this particular data is pointing more towards middle cerebral artery. So basically, I just had a talk with my, neurosurgeon friends as well on what the neurosurgery textbooks also had to say. So, I just talked to one of my friends also today. So he also sent me multiple references. See, what is the general consensus now is that when you take all the aneurysms, including the unruptured, incidentally detected aneurysms, some data is skewed towards middle cerebral artery. Now, if the question was about anterior communicating artery, then according to certain data, it would have been that. But again, you can see that the Harrison reference is slightly tilting towards middle cerebral artery. See, I'll be very honest here, even I have got some confusion for this because even after talking to multiple colleagues, neurosurgeon friends, because, for this particular aspect, I think we'll have to rely on the neurosurgery textbooks as well. So there is a doubt to this question. Honestly, I'm not very confident on what the answer to this exactly is, what to pick, whether it should be anterior cerebral artery or should it be middle cerebral artery as per some recent data as well, especially since it has been, shown in an image in the 22nd edition of Harrison. So that is just, I wanted to tell you this because I know that many of you would have thought, okay, it is anterior cerebral, but there is some data pointing to MC as well. So there is a bit of confusion in this. Because according to certain textbooks, it is proximal part of the ACA-ACOM junction, but MC aneurysms are also more common. So let me accept that there is a bit of controversy in this. Okay, so accepting the controversy, I'm moving to the next question. Okay, right. See, that is medicine. Medicine is, it's not like I cannot say that I know everything about medicine, or nor can anybody say. So that's how the subject makes all of us humble. Okay, right. Okay. All right. So coming to the next question, a 20-year-old athlete collapses suddenly during a practice session and is pronounced dead by the attending physician. The autopsy gross image is shown. Which of the following statements is right? So from what I understand from the students is that the gross image was favoring the hypertrophic obstructive cardiomyopathy with a significant hypertrophy involving the left ventricle as well as the septal region. So that was something that most of the students agreed upon on the gross image. Now, when you have got such a young athlete collapsing all of a sudden with this autopsy gross image, I don't think there should be any such confusions. Most likely, this is a case of hypertrophic cardiomyopathy. And which of the following statements is right is being asked. So the first question was something in the lines of first option was something in the lines of myocardial infarction, check cholesterol levels. Well, that will not be the answer here. No other findings favoring a myocardial infarction, especially the age of the patient, no mention of any sort of chest pain, nothing about ECG change, nothing. So cardiac arrest due to valvular heart disease, nothing to suggest a valvular heart disease here. Then hypertrophic cardiomyopathy, yes, and screening of the first degree family members. And why is screening given? Because why is screening done? Because this is autosomal dominant inherited condition. So there is a strong predisposition to involve multiple members of the family is what you should understand. The other one, commotio cordis due to trauma, no mention like that, and autopsy is also not suggestive of that. So for this question, the answer is going to be option C. Okay, right. A 35-year-old woman with a history of hypothyroidism presents for evaluation. She recently completed a 13 to 14 hour long flight. She is also taking oral contraceptive pills and also has a history of smoking. Which of the following factors increases her risk of developing venous thromboembolism? The options being oral contraceptive pills, prolonged immobilization during the long haul flight, smoking, and hypothyroidism. What do you think? So the patient is having multiple issues here. The question is quite straightforward on the risk factors for developing venous thromboembolism. So as you can see from this screenshot in Harrison, the predisposing factors for development of venous thromboembolism, you have got cigarette smoking as a risk factor, long haul air travel again as a risk factor, oral contraceptive pills also as a risk factor, but hypothyroidism has not been mentioned as a direct risk factor causing deep vein thrombosis. So for this question, let us look at the options here. Oral contraceptive pills, yes, is a risk factor. Prolonged immobilization, yes. Smoking, yes. So from what I could gather from the options, the best one is A, B, and C would increase her risk of developing thromboembolism, right? Okay. All of the following have same mechanisms of developing heart failure except options are fever, thyrotoxicosis, anemia, and high salt intake. So if you look at the options, the mechanism of heart failure for three of the options are almost the same, which are the first three options. Because fever, thyrotoxicosis, and anemia, they are examples of high output cardiac failure, and this occurs because of the increased demand. Whereas in case of high salt intake, the mechanism of heart failure is related to the volume expansion, related to the solute load that has been added to the body. Per se, high salt intake alone might not lead on to heart failure, but can contribute to worsening of an existing cause of heart failure. So because of that, the best answer for this question will be high salt intake. Okay. Which of the following are included in major or minor Jones criteria for the diagnosis of rheumatic fever? The options: erythema nodosum, subcutaneous nodules, shortened PR interval, carditis, chorea. So we know that looking at the options. Okay, let me tell you Jones criteria for acute rheumatic fever. Again, important topic for exam. Now the question is which of the following is included either in major or minor criteria? Is erythema nodosum included in the criteria? No, it is erythema marginatum that is included in the criteria. Is subcutaneous nodule included in the criteria? Yes. Is shortened PR interval included in the criteria? No, it is long PR interval. Is carditis included in the criteria? Yes. Is chorea included in the criteria? Yes. So the answer will be option B, D, and E. So these three, B, D, E, and E, are included in the Jones criteria. Clear? Okay, right. A child presented with recurrent lung infections. On examination, a continuous murmur is heard in the left infraclavicular area. What is the most likely diagnosis? A simple, straightforward question. I don't think I should be discussing this as well. We have discussed when you think about a continuous murmur in the left infraclavicular area in a child predisposed to develop recurrent infections. Yes, it could be patent ductus arteriosus. You get the machinery type of murmur of PDA. Answer is option C. Systolic blood pressure falls slightly during normal inspiration. This is because of, again, something that we have discussed in our routine lectures. In the initial part of my cardiology lectures on the clinical cardiology part, I have explained this with a figure as well. So this is very simple. The reason being increased venous return to the right ventricle, and I've showed you that the filling of the LV is compromised, and that is the simple reason. Answer is option A. Which of the following statements is true about acute rheumatic fever? Option A, ash of bodies are seen in the heart? Option B, it is caused by group B streptococcus. Option C, in acute cases, the aortic valve ruptures. And option D, it only causes myocarditis. So coming to the first option, it is a correct one, right? Ash of bodies are seen in the heart in acute rheumatic fever. Is it caused by group B? No, it is caused by group A beta hemolytic streptococci. In acute cases, aortic valve ruptures. Well, acute rheumatic fever is not a common condition where you get a valvular rupture as in case of infective endocarditis. And about the valve involvement also, the most commonly involved is the mitral valve. So this is again definitely a false statement. It causes only myocarditis, definitely wrong, because in acute rheumatic fever you can have involvement of endocardium, myocardium as well as pericardium. So the answer for this question will be option A. Ash of bodies are seen in the heart. Tall P waves on ECG are most commonly associated with which of the following conditions? Is it mitral stenosis, tricuspid stenosis, mitral regurgitation, or aortic regurgitation? So question is on tall P waves on the ECG. Okay. Now, when you have got tall P waves on ECG, probably the reference is to P pulmonale. Okay, probably the reference is to P pulmonale. The height is more than 2.5 millimeter. Okay. Now, when does P pulmonale occur? It occurs in conditions of RA overload. It occurs in conditions of RA overload. Okay, or RA enlargement. Now, out of the options given, tricuspid stenosis definitely can predispose to an RA overload. So definitely you can get tall P waves. Now mitral stenosis, we know that there is P mitral in mitral stenosis. But in the clinical course of a patient with mitral stenosis, if pulmonary hypertension develops and subsequently there is an RV involvement in the form of RV hypertrophy, then there is a chance that you may get P pulmonale as well. But in the question, since the mention is just of mitral stenosis and not a specific mention of mitral stenosis with pulmonary hypertension, I am more inclined towards answering tricuspid stenosis for this question. Okay. Which of the following drugs used in pulmonary hypertension is a prostacyclin receptor agonist? Again, this topic I have discussed along with cardiology, and we have discussed in detail about the topic of pulmonary hypertension, including the drugs used and the mechanism of action as well. So the answer for this question will be selexipag. Okay. So if you look at the drugs, the most important ones used in pulmonary hypertension, we have got endothelin receptor antagonist like bosentan, ambrisentan, the phosphodiesterase 5 inhibitors like sildenafil, prostacyclin analogs like ipoprostenol, iloprost, and treprostinil, the soluble guanylate cyclase stimulator, that is riociguat, and prostacyclin receptor agonist, which is selexipag, which has been asked for this particular question. The answer here will be option A, selexipag. Okay, right. A patient presents with frothy urine, no history of hematuria. Serum creatinine was 2 mg/%. Which among the following factors can be used to support the diagnosis of nephrotic syndrome? Option A, not option A, the ones which were given are proteinuria more than 3.5 gram per day, hypoalbuminemia, hyperlipidemia, and serum creatinine. Now for this again, I just want to know the exact wordings of the question. If the question was just which of the following parameters can be used to support the diagnosis of nephrotic syndrome, then yes, proteinuria is going to support, hypoalbuminemia is going to support, hyperlipidemia is going to support, but serum creatinine is not going to support a diagnosis of nephrotic syndrome. So if this is the wording, then the answer would be A, B, and C. But if there was a specific mention on the absolute need of something in the diagnostic criteria, then please understand hyperlipidemia is not essential to make a diagnosis of nephrotic syndrome. If you look at this, you can see from Harrison itself, The defining features of nephrotic syndrome are edema, hypoalbuminemia, and proteinuria. Yes, and if you go through the KDIGO definition as well, you can see that to make a diagnosis of nephrotic syndrome, what is required? You need a nephrotic range proteinuria with either hypoalbuminemia or edema. Okay, so the essentials are definitely nephrotic range proteinuria and hypoalbuminemia. Okay, or edema when the albumin level is not available. So that is why I just want to exactly know the framing of the question. So that is only when you can come to an exact diagnosis. Okay, so for this question, answer will be option C. So that is what, my dear children, you should understand. When we deliver a recall session, we are doing this after hearing your version of the question. But again, every word is important. So that can actually change the answer. So it depends on the wordings of the question. That is what I want to know from you. So in the comment section, I can see Sumit is saying that criteria only. Somebody is saying diagnostic criteria was there. So it all depends on the exact wordings of the question. But I have given you the essential core concept which my children should know, so that for the subsequent exams, in case you are a future aspirant, you will be you'll be comfortable. Okay, right. High anion gap metabolic acidosis is seen in which of the following conditions? Starvation, diabetic ketoacidosis, severe vomiting, and again, multiple options were right here. So the question is regarding HAGMA, high anion gap metabolic acidosis, HAGMA, right? And if you look at the options, what about starvation? Definitely can cause high anion gap metabolic acidosis. What about diabetic ketoacidosis? Definitely can cause high anion gap metabolic acidosis. But when it comes to vomiting, it is going to cause not metabolic acidosis but metabolic alkalosis. So hence this option can be eliminated. So if you look at this, option A and option B, starvation and diabetic ketoacidosis are the causes of high anion gap metabolic acidosis. So this is the table from Harrison showing the various causes of high anion gap metabolic acidosis. Clear? Okay. A child presents with proteinuria that does not respond to corticosteroid therapy. The renal biopsy shows segmental areas of sclerosis on histopathology. What is the most likely diagnosis? So is it IgA nephropathy, minimal change disease, focal segmental glomerulosclerosis, or membranous nephropathy? So child with proteinuria, usually in the context of nephrotic syndrome, most likely it will be minimal change disease. But in this particular case, the patient is not responding to steroid therapy. So chance of MCD comes slightly down. Okay. But again, look at the renal biopsy. We know that in case of minimal change disease, the LM is normal. Okay. So here you can see that on histopathology, there are segmental areas of sclerosis. So that is taking the diagnosis definitely away from that of minimal change disease. So what is the most likely diagnosis here? What do you think? This is most likely to be, you are not going to get this in case of IgA nephropathy, not minimal change disease, not membranous nephropathy. This should be focal segmental glomerulosclerosis. In minimal change disease, LM is normal, that is light microscopy is normal. Electron microscopy will show effacement of food processes. If it was IgA nephropathy, again, you will have changes involving the mesangium, IgA deposition, that again not mentioned. So again, the correct answer for this question will be option C, FSDS. Okay, right. Another simple question, an image showing a characteristic hand deformity. Identify the deformity depicted. So this was regarding a flexion involving the proximal interphalangeal joint and extension involving the distal interphalangeal joint. So the diagnosis is going to be a Boutonniere deformity. In the lectures, I think in my workbook, both for online and offline, you've got certain images. I think Boutonniere, swan neck, Z deformity, piano key, all the deformity images I've given. But again, no need of any coaching itself to answer this. You have learned this during your MBBS days itself. Answer is option A, Boutonniere deformity. Okay, right. A woman presents with dryness of mouth, gritty sensations in the eyes for several months, and bilateral salivary gland enlargement. Again, history-wise, strongly suggesting towards Sjogren syndrome, right? Laboratory features shows hypokalemia and metabolic acidosis. We very well know that renal tubular acidosis type 1 and significant hypokalemia are features that favor Sjogren syndrome. What is the most appropriate investigation to confirm the diagnosis? It is not going to be acetylcholine receptor antibody. Salivary gland scintigraphy can be used, but not a primary diagnostic investigation. Serum calcium levels and AC levels not having much role, only has supportive role in the evaluation of sarcoidosis. So this is not going to be the answer. So here Schirmer's test, because the patient will be having abnormality in the tear film, and autoantibody profile, because the patient is likely to have a positive anti-nuclear antibody, the positive anti-SSA and a positive anti-SSB. These are the findings that are likely to be present in this particular patient. Okay, right. According to the GOLD criteria, which of the following classifications of COPD severity based on spirometry is correct? And you've got ABCD and a combination of options. So this again from the same screenshot I've put as in your workbook of pulmonology. I've shown you that the classification of airflow limitation severity in COPD is important. And what did I say? This is based on the post bronchodilator FEV1. And to be eligible for the GOLD classification, the patient should have an FEV1 to FVC ratio less than 0.7. So if you take GOLD 1, 2, 3, 4, the first two options are actually correct. You know, they are suggestive of mild and moderate severity in case of the GOLD criteria. But look at severe as well as very severe. So here the mention is regarding 40 to 50% and less than 40%. That is wrong. This is about 30 to 50% and less than 30%. So the last two are incorrect. So if the question is which of the following are correct, then it has to be A and B are correct. Okay, that is clear. The answer is going to be option A, right? 67-year-old male presents with gradually progressive tingling and numbness in the right upper limb for 3 months. So the patient has got some sort of sensory symptoms in the right upper limb, an elderly male. He also reports right eye visual disturbances, and examination shows ptosis and anhidrosis. Chest X-ray shows apical lung lesion. This combination is enough and more to substantiate a diagnosis of Pancoast syndrome, correct or not? But what is the question? What is the most appropriate investigation to confirm the diagnosis? So the chest X-ray is showing a mass lesion involving the lung apex. Clear? Okay. So we know that when you have got a superior sulcal tumor or a Pancoast syndrome, this can compress upon the lower trunk of brachial plexus in the C8 T1 roots, and because of which the patient can have the sensory symptoms involving the right upper limb, and there can be Horner syndrome, the symptoms of which have been symptoms and signs of which have been mentioned in the question. So what do you think? To confirm the diagnosis, what should you be doing? Options are nerve conduction study. Well, nerve conduction study will show abnormality involving nerves, no doubt, but that is not going to confirm the etiology, because you want to find out the diagnosis, not a nerve involvement per se. So this is not going to be the answer. Nerve conduction study. Ultrasonography, again, no. In case of an apical lung lesion, what are you going to get additionally by ultrasonography? No. Sputum microscopy, again, nothing suggestive of a picture like that in the question. Okay. And CT guided biopsy. This is correct, because you need to have a tissue diagnosis now. And for tissue diagnosis, you have to go for biopsy. But if the question was, suppose the question was the investigation to identify the extent of the lesion or to stage the disease, then what would have been the answer? Suppose in the next exam they ask such a question, then the answer would have been MRI in case of Pancoast syndrome. So here, to make a tissue diagnosis, you will have to go for a CT guided biopsy. Answer C, CT guided biopsy. Okay, right. And just to show you from Harrison, again, the pain characteristically involves the ulnar surface of hand. I told you it is involving the C8T1. Horner syndrome can be present because of the involvement of the sympathetic chain as well. Okay, right. A 30-year-old HIV positive male presents with low-grade fever and cough for 1 month and 1 episode of hemoptysis and low-grade fever. Chest X-ray is shown. What is the most likely diagnosis? So the chest X-ray, according to some students, there were infiltrates involving the lung apex. Some students told that there was some finding of cavity as well. So whatever it be, that is not going to change the answer when you have got such infiltrates involving the lung apex in a patient who is retropositive, presenting with low-grade fever and cough for 1 month with hemoptysis. This is suggestive of an infective process, a fever for 1 month. So if you look at the option, lung metastasis, no. Lung abscess, again, it's a low-grade fever only. And the findings are also more of infiltrates in the lungs is what the students actually told, and not a low-grade fever and cough for 1 month. And so that also I'll be eliminating. Pneumothorax, again, neither the clinical presentation nor the imaging was suggestive of pneumothorax. So considering the clinical history supported by the imaging finding, the answer is option A, pulmonary tuberculosis, right? Okay. A male patient who is a smoker presents with sudden onset breathlessness. On evaluation, he has decreased breath sounds on both sides and tachycardia. What is the next line of management? According to students, they all told me that there were 2 images for this question, and both the images substantiated the diagnosis, wherein it was a bilateral pneumothorax. A bilateral pneumothorax evident in the chest X-ray, evident in the CT scan as well. So what is the next line of management was asked. Nerve needle aspiration was option A. Definitely yes, this has to be considered. Bilateral pneumothorax and patient is symptomatic. So there is no question of observing the patient and keeping him. You will have to do a needle aspiration, which is correct. And for some reason, the examiner is interested in nerve conduction velocity here. Even I was asking the students as well, is it actually NCV? Did they actually ask something about non-invasive ventilation? They said, no, sir. The examiner was asking about nerve conduction velocity. I don't know why nerve conduction velocity should even be considered in this particular case. So anyway, that is a wrong option. Collect sputum and start anti-tubercular therapy immediately. Again, does not make any sense. PET CT also is not going to be the answer. So this is a case of a bilateral pneumothorax, the management of which was asked. Needle aspiration would be the answer. Which of the following conditions carries the highest risk of developing invasive aspergillosis? Options are febrile neutropenia, bronchial asthma, HIV infection with a CD4 count less than 50 cells, and severe protein deficiency. So let us see what are the important risk factors for development of invasive aspergillosis. So if you look at Harrison, you can see that the primary risk factors for invasive aspergillosis, number 1, profound neutropenia, then number 2, glucocorticoid use, and number 3, underlying respiratory disease. So profound neutropenia, as in case of a febrile neutropenia, is always going to predispose to development of invasive aspergillosis. So this definitely has to be one option in serious consideration. What about bronchial asthma? Please understand, bronchial asthma is associated with allergic bronchopulmonary aspergillosis and not with any sort of invasive aspergillosis. Then what about HIV infection? Do you think HIV infection per se would increase the risk of developing invasive aspergillosis? Please have a look at Harrison again. You can see that this particular screenshot from Harrison, invasive aspergillosis is not an AIDS-defining illness and is generally not seen in patients with AIDS in the absence of neutropenia or administration of glucocorticoids. So retroviral infection per se is not significantly increasing the risk of developing invasive pulmonary aspergillosis. So for this particular question, if you look at option D as well, so I'm eliminating this option Option C, and severe protein deficiency. It is not again not at least related to invasive pulmonary aspergillosis. So that option is also out. Answer is option A. 60-year-old chronic smoker with chronic obstructive pulmonary disease presents with increased sputum production and worsening of shortness of breath. His respiratory rate is 30 per minute, pulse rate 112 per minute, oxygen saturation 86% on room air. The patient was having type 2 respiratory failure. According to the GOLD guidelines, which of the following constitutes the most appropriate initial management for his acute COPD exacerbations? So there was mention of antibiotics, steroids, antiviral therapy, and nebulized bronchodilators. So please look at this patient. He is having a severe exacerbation of COPD. Yes or no? He is having a severe exacerbation of COPD. And the presence of sputum, increased sputum production. So when a patient with COPD has increased sputum production, you should definitely think about a superadded infection. Yes or no? There is a possibility of a superadded infection. And patient is having respiratory distress, no doubt. The patient is having a drop in oxygen saturation. He is in respiratory failure. So coming to the options, antibiotics, what do you think? Since there is a specific mention of increased sputum production, I would go for antibiotics also. If that point was not there, I would not choose antibiotics in the routine treatment of a severe exacerbation of COPD. Right? Okay. Okay. But there is a specific mention of increased sputum production. Then systemic steroids. Definitely, yes, steroids can be used. Steroids can be used. Then antiviral therapy. Antiviral therapy is not having any role. What about nebulized bronchodilators? Definitely is having a role. So which of the following constitutes the most appropriate initial management? So that would be A, B, and D. This will be the answer, A, B, and D. Okay, A, B, and D. Antibiotics, steroids, and nebulized bronchodilators. In my lectures, I have shown you the exact treatment guideline as well, and that is just what I am repeating out here. Okay, right. This again is a slightly controversial question, but I'll just tell you my viewpoint. Hypoxemia in patients with chronic obstructive pulmonary disease is most likely to occur when the FEV1 percentage of predicted falls below which of the following levels? 30%, 40%, 50%, 60%. So for this again, we'll have to go to the GOLD. So according to the airflow limitation, we have got mild, moderate, severe, and very severe. So when I looked into the literature, there is no definite mention that FEV1 percentage has a direct correlation with the hypoxemia. At what levels? I couldn't find in any of the textbooks. But generally what is considered is that it is when the patient goes to GOLD 3 stage that patient starts developing features of hypoxemia. So in terms of the FEV1 percentage, it is usually when it drops below 50%, which is option C, severe. And it happens much before it is very severe. So anytime it drops below 50%, that is when hypoxemia is most likely to occur. Option C would be the best answer here. Okay. A patient presents with progressive dry cough and shortness of breath. HRCT findings were shown in the question. Which of the following statements are incorrect? Patients with this condition should receive H. influenzae and pneumococcal vaccination. The condition is most commonly seen in patients with rheumatoid arthritis. Honeycombing and reticular pattern are typically seen, and inspiratory coarse crackles are very common. So from the recall that I got from the students, they said that in the image, there was definite ground glassing appearance. There was definite ground glassed appearance. There were no changes of usual interstitial pneumonia is what the students said. So if you consider that as the right recall, then coming to the first one, yes, there is a role for H. influenzae and pneumococcal vaccination to prevent infections in patients with interstitial lung disease. The condition is most commonly seen in patients with rheumatoid arthritis. That is not correct. Okay, it is an incorrect statement. Okay, because in rheumatoid arthritis, you are most likely to have patient with usual interstitial pneumonia type of pattern. Coming to the next option, honeycombing and reticular pattern are typically seen. In this particular case, no. Honeycombing and reticular pattern are again suggestive of usual interstitial pneumonia pattern only, UIP pattern. End inspiratory course crackles, again it is correct only. So they are asking about which of the following statements are incorrect. So if this was the question framing, then the answer would be the options B and C. This would be the answer for this question. Okay, right. A patient presents with recurrent gastric ulcers and a nodule located on medial side of the second part of duodenum. What is the next appropriate investigation? Options: serum gastrin, serum parathyroid hormone, serum insulin, and serum catecholamines. So when you have got a patient with recurrent gastric ulcers and there is a nodule located in the second part of duodenum, this is probably a scenario where you should consider a gastrinoma developing as a part of Zolliger-Ellison syndrome in the gastrinoma triangle. Okay, so in that case, what is going to be the most appropriate next investigation? It has to be serum gastrin levels. Option A will be the answer. Okay. Most common cause of viral diarrhea in adults. The answer is straightforward. It is norovirus. Norovirus is the answer. Okay, right. Onion skin fibrosis is seen in which of the following conditions? This is a characteristic description of the pattern of fibrosis involving the primary sclerosing cholangitis, that is PSC. That is going to be the answer. A healthcare worker who has been previously vaccinated against hepatitis B sustains a needle stick injury from a patient who is HBsAg positive. Next line is very important. The worker's record shows that they are a non-responder to vaccine. What is the most appropriate next step in the management? I couldn't gather all the options, but from what I understood from the students, there was an option 2 doses of HBIG 1 month apart. Yes. Now, I have taught you in my lectures, I am just showing the screenshot, okay, of the post-exposure prophylaxis. So I've told you in case of the non-responders, vaccinated patients can be responders or non-responders. So in non-responders, one strategy is HBIG plus vaccination. But what if he is a recurrent non-responder? Recurrent non-responder to vaccine, then what is the option that I told you in class? HBIG 2 doses 1 month apart. And that will be the answer here. So that is the answer for this question. Okay, right. Now, can somebody in the chat box let me know? Okay, let me know if this was there in the option or not. Okay. So, was this option in there or not? 2 doses of HBIG. So one query by a student, rheumatoid arthritis can also produce a clinical picture, was in the option for that question on the NSIP pattern, right? In fact, RA can also produce. So that depends. What was the wording? Can RA produce NSIP pattern? Possible. But what is most common? UIP pattern. That is what I said. You will have to decide based on the wordings of the question. I have not given the exam. Okay, right. So yeah, so I assume that this was there in the option. So Scalpel in the making has said that this was there in the option. So I assume that this was the option and this will be the answer for this question. Okay, right. Okay, right. Next is Tigar O is used for. So essentially this is for chronic pancreatitis. It is nothing but a list of the possible etiologies causing chronic pancreatitis. So if you can see here, T stands for toxic metabolic. Okay. I stands for idiopathic. G stands for genetic. A stands for autoimmune. R stands for recurrent and severe acute pancreatitis. And O stands for obstructive. Okay. So the answer here will be chronic pancreatitis will be the answer. Which of the following is not a hallmark feature of Conn's syndrome? Options being hypertension, metabolic alkalosis, hypokalemia, and hypernatremia. Not a hallmark feature. Is hypertension a hallmark feature? Yes. So that is not going to be the answer. Can there be metabolic alkalosis? Definitely yes. Can there be hypokalemia? Definitely yes. Significant hypernatremia does not occur in Conn's syndrome. Either the sodium is mildly elevated or may even be normal. What is the reason? For the compensatory natriuresis that occurs as a part of the pathophysiology of Conn syndrome, which I have discussed in my lectures as well. So for this particular question, the best answer will be D, that is hypernatremia. Okay, right. 50-year-old male presents with bone pain. Serum calcium is elevated, phosphate is low, and serum alkaline phosphate is elevated. X-ray shows diffuse osteoporosis. What investigation will be useful for the diagnosis? So please understand, in a patient with bone pain, with elevated calcium, low phosphorus, and elevated serum alkaline phosphatase, what are you thinking about? This could be very well representing hyperparathyroidism. And X-ray is also showing diffuse osteoporosis. What investigation will you use for confirmation of diagnosis? So when you think about primary hyperparathyroidism, what is the likely etiology? This could be due to a parathyroid adenoma. This could be due to a parathyroid adenoma. So what is used for confirmation of diagnosis? Is it MRI scan? Is it sestamibi scan, bone marrow biopsy, or triple phase bone scan? Well, we have learned this. It's a favorite question for INI-CET as well. It is technetium-99 sestamibi scan. You can combine it with the 4D CT as well. Okay, so it is going to be the sestamibi scan. Option B will be the answer for this question. Okay. A patient with centripetal obesity and striae who is a non-case of SLE on long-term steroid therapy presents for evaluation. What is the most appropriate investigation to diagnose the condition? Options: low-dose dexamethasone suppression test, low-dose dexamethasone suppression test followed by high-dose dexamethasone suppression test, blood cortisol followed by ACTH levels, and high-dose dexamethasone suppression test. See, first thing you have got to understand for this question, are we dealing with a scenario of exogenous Cushing or endogenous Cushing? You tell me. Exogenous or endogenous? Patient is a case of systemic lupus erythematosus. Patient is on steroids. Okay, and then has developed Cushingoid features. This is clearly a case of exogenic or iatrogenic Cushing syndrome. Now, all the suppression tests that you are using is in the context of endogenous Cushing or exogenous Cushing. It is in the context of endogenous Cushing syndrome. So, I am not needing any sort of suppression test here. What I will do is, I will look at the blood cortisol level. Please understand that in case of exogenous Cushing syndrome, because of the suppression of the axis, okay, the cortisol level, you know that for endogenous Cushing, the cortisol will be increased. But exogenous, you are giving outside steroids. And please understand, for exogenous, the body's cortisol production will be reduced only. So the body's, cortisol, if you look, it will be reduced because of the suppression of the HP axis, followed by ACTH levels. Again, as I told you, there is a suppression of the ACTH axis. So that is the difference you have got to understand, endogenous and exogenous Cushing syndrome. Exogenous, the cortisol will be elevated. Sorry, endogenous, cortisol will be elevated. What about ACTH? Depends on what is the cause for the endogenous Cushing. Whereas in case of exogenous Cushing, blood cortisol level, the body's cortisol will be decreased and the ACTH levels also will be decreased because of the suppression. So if a reduced blood cortisol with reduced ACTH, that is what is the answer. You are not going to go for suppression test for exogenous Cushing syndrome. Okay, right. So Harshit is asking, saying that ACTH plus whatever it is, the answer is going to be, no need to look for any other options. Whatever be the framing, this is going to be the answer. Option C is the answer. Okay, right. A patient with type 2 diabetes mellitus is planned to start therapy with DPP-4 inhibitor. He is also receiving ketoconazole for a fungal infection. Which of the following DPP-4 inhibitors requires a dose adjustment due to interaction with ketoconazole? So we know that ketoconazole is an inhibitor of CYP3A4. And out of the given options, there is only one of them which is metabolized by that, because of which there can be alteration in drug levels requiring dose modification. That will be saxagliptin. Option B will be the answer. Which hypothalamic nucleus plays a key role in the development of leptin resistance? Again, a factual question. The answer for this will be arcuate nucleus. Option C will be the answer. Which of the following is the best recommended for HIV pre-exposure prophylaxis? So what exactly is HIV pre-exposure prophylaxis? Important. So HIV pre-exposure prophylaxis means you are using antiretroviral drug to prevent HIV transmission. And for whom is this used? For high-risk individuals. That is partners of HIV positive individuals who are having a significant viral load, then MSM and transgenders and IV drug abusers. These are some of the high risk populations where this might be indicated. And when it comes to the regimens, the pre-exposure prophylaxis regimen, see the screenshot from Harrison. The recommended regimen is a combination of emtricitabine plus the tenofovir disoproxyl fumarate. So you have got two regimens mainly. Okay, so and both the regimens include tenofovir, one of which is the TDF and the other is the alafenamide preparation as well. The preferred one is the TDF itself, that is the tenofovir disoproxyl fumarate, that is again mentioned in Harrison as well, which can be given either as daily regimen or on demand. Also it can be given. There are two ways of giving it. So this is the preferred regimen for the HIV pre-exposure prophylaxis. So tenofovir with emtricitabine will be the best answer for this question. Okay, right. A patient presents with features of meningitis. CSF ELISA for cryptococcal antigen was found to be positive. Which of the following is the most appropriate initial therapy for this patient? Now this is another scenario where I want the exact recall. So you look at this. Which of the following is the most appropriate initial therapy? This is one version of the recall that I got. Okay, now you have to tell me whether this was the exact recall or not. And see, it is amphotericin plus flucytosine, amphotericin plus fluconazole, fluconazole alone, or liposomal amphotericin B plus itraconazole. Now, if you look at the regimens which are preferred by the NACO, so there is a preferred regimen and certain alternative regimens. The preferred regimen is the best regimen, where for the induction phase, as you can see, for cryptococcal meningitis, you have got an induction phase, consolidation phase and maintenance phase. In the induction phase, you can see you are giving amphotericin B and flucytosine, followed by fluconazole. Yes, followed by fluconazole. There are certain alternative regimens, and even one regimen, suppose if you don't have flucytosine, where the availability is not there, then as an alternative, you can consider amphotericin B plus fluconazole. But it is only an alternative and used in the scenario that I just mentioned you about. Okay, so that is what was mentioned. And I can see in the comment section a few of the students telling that it wasn't a multiple correct is what some students are telling. So can you please confirm that in the chat section? Okay, right. So Harshit, for the previous question, you're asking tenofovir plus lamivudine, right? No, tenofovir plus lamivudine is not a preferred regimen. It was one of the considered regimens earlier, but remember, we are talking about pre-exposure prophylaxis, not post-exposure prophylaxis. Okay, right. And yeah, please confirm this. Anyway, I'll just describe. Okay, you can, whatever is the answer, whether multiple response or single response, I'll tell you the basic concepts and you can decide. So anyway, if I am thinking this to be the answer, most appropriate initial therapy for me, it will be amphotericin plus flucytosine A only. If the question was which all regimens can be used, then this is also a possibility, amphotericin B plus fluconazole. But I told you what is the scenario in which it is used. The other two, no. So whether the question was best initial therapy or not used, whatever it is. Okay, but okay, I can see in the comment section two students are differing in the response. Like somebody is saying it was multiple response, somebody is telling it is not. I think it was, is what majority of the students told me. Okay, that is what I understand from the students. So for this, the option is A only. If you are convinced with this, can you give me a thumbs up? If you are convinced with what I told you, the concept is clear or not? There is something that is a preferred regimen, and there are certain alternatives as well. Yes or no? Right. So somebody is asking why not liposomal amphotericin? Itraconazole, that combination is not preferred. So that is why it is not the answer. Okay, right. and you're not going to go for fluconazole alone as well. Okay. Okay. A patient is diagnosed with miliary tuberculosis, is found to be HIV positive. What is the most appropriate management plan? So TB, HIV co-infection, again important. I've always told you, you are scared about what here? Immune reconstitution inflammatory syndrome, that is IRIS. So since that is the case, what will I do? I will start with ATT first. Okay, I'll start with I'll start with ATT first, and then ART after 2 weeks. Because otherwise, you know what will happen. Because of the immune reconstitution, there can be IRIS, and you will have to go for increased dose of dolutegravir as well, which I have told you in my lectures also. You can see here in the NACO table as well on dolutegravir, you can see the dose is 50 milligram, but the dolutegravir dose, it has to be increased 50 milligram twice daily, because rifampicin can interact with dolutegravir. So in the presence of rifampicin, the dolutegravir dose must be doubled. So that is what you have to go for, an increased dose of dolutegravir as well. Okay, right. A patient presents with hemoglobin of 9 gram per deciliter and MCV of 73. So scenario is that of a microcytic hypochromic type of anemia. Which of the following conditions should be considered in the differential diagnosis? So definitely I am going to consider iron deficiency, thalassemia and lead poisoning. But the last option, vitamin B12 deficiency, it is only that of macrocytic anemia. So here the answer will be A, B and C. The option B will be the right answer for this particular question. Okay, right. Coming to the next question. 25-year-old patient presents with a history of fever for the past 4 days. No bleeding manifestations, vitals are stable. Laboratory evaluation reveals hemoglobin of 9 and platelet count of 20,000. So a short febrile illness with thrombocytopenia was the scenario that was given for the exam. And there was a specific mention, as I understand, that there were no bleeding manifestations. Okay. What is the most appropriate management step was the question in the first hour. Steroids, platelet transfusion, paracetamol, whole blood transfusion. See, assuming that this is a case of, say, a dengue fever or any sort of an infectious process, steroids are not acutely indicated here. Okay, right. Next is platelet transfusion. Now, the platelet count is 20,000. No bleeding manifestation. So, remember, what is the cutoff as per the current guideline? For a patient with thrombocytopenia without bleeding manifestation, if you want to give platelet transfusion, the count should be less than 10,000. Here it is 20,000. No need. Paracetamol definitely can be given. Okay, so this can be given for the fever. Whole blood transfusion, again, no particular indication in this case. So from what I understand, the option was C only. So this will be the answer here. C only will be the answer for this question. Okay. The Nobel Prize in Physiology or Medicine for 2025 was awarded for discoveries concerning which of the following? So it is peripheral immune tolerance. So the Nobel Prize was shared for the discovery of the peripheral immune tolerance by these three. Okay, right. So that's it. We have discussed the medicine recall questions from whatever I could gather from the students. So for all those students who helped me in formulating the recall, a big thank you, because you guys in my INI-CET group helped me a lot with framing the, at least not the exact, but almost near exact that I would say. But I know that relatively we have come close to a good recall is what I understand. So if you have got any other queries or any more questions that were asked for this particular exam, you can message me in Instagram. So this will be my Instagram ID, dr_Rahul_Rajeev. So you can message me in Instagram. So in my academic WhatsApp groups, I have also shared the PDF of this particular recall as well. So I hope all of you have got this as well. So in the academic groups, I have shared. So that's it. I hope the recall discussion was useful for all of you. So for all my children who have given the INI-CET exam, I hope that God helps you and luck is in your favor as well. Because for such exams, a bit of luck also is necessary. I know that. But again, ultimately, it's all about the effort that you have put in. The luck element will just augment your scores, but the major deciding factor is going to be the effort that you have put in. Looking forward to hearing from you after the results have been announced, and we hope that you all get very good ranks as well. And for the students who couldn't do well for INI-CET, please understand that a single exam doesn't decide your future. Maybe you get a setback for this exam, that will happen, but there is always an opportunity to come back. But when you bounce back, please look at what went wrong. And even for students who are seriously preparing for the NEET PG 2026, this INI-CET is like a real-time GT check to assess what is going on in your preparation phase. Even if you have not completed all subjects during your preparation phase, what you can do is, at least for subjects that have been completed, you please analyze your performance on how you have been doing. Okay, whether you have made careless mistakes or not, how was your revision, like that. You have to be thorough. Okay, that is what I would tell you. I wish all the good luck to all my dear students.